So good morning and thank you for joining us for this Policy Interested Parties meeting. I'm Amelia Boyd and I am the Program Manager for the Medical Commission and the facilitator for this meeting. This meeting is being recorded. The purpose of this meeting is to collaborate with interested parties such as the public, association members, physicians, and physician assistants regarding our policies, guidance documents, and interpretive statements. The documents which will be discussed here today are available on the policy meetings page on our website, which is wmc.wa.gov. Kyle Kiernan, our executive director, and Micah Matthews, our deputy executive director, are the presenters for these meetings. Attendees, if you would like to ask a question or speak, please use the raise your hand function or the chat. When commenting, we request you avoid commenting on ongoing investigations or disciplinary cases. And then please make sure your comments pertain to the agenda items until we get to the open forum section. Are there any questions about any of that? Doesn't look like it. So with that, I will pass it over to Micah to start the agenda, and I will change my share screen.
Thanks, Amelia. Good morning, everyone. So we've got a fairly short agenda, but there's some fairly significant changes here, and the main thing is as I've been going through here, I've been wanting to try and reduce the number of our guidelines and policies and as we can. So this is an example, this first one of attempting to do that. So we've had historically two guidelines. One is communicating diagnostic test results to patients. And then the other one is the time critical one, and that's more designed to be between practitioners, but there is an element of time critical communication of test results in both of these, regardless of the receiving party. So what you see before you in the packet is an attempt to combine both of those into a single policy. And we're obviously happy to take any comments that people might have. And I fully recognize this is kind of a mashed together approach, but it felt more customer service centric to be able to find all of what you needed in one place and in one document. So at that point, I will leave it open for comment, and if anybody would like to comment on the document before them.
There's no hands raised.
Okay.
No comments in the chat yet.
In that case, respecting the fact that we've got a guest who I'm going to ask to speak to their edits, let's move on to the second one. So this next one is an update. So we typically try not to have procedures, or we're trying to weed out procedures in our guidance documents, and so that's part of what's going on here. We sent, because it has direct implication to licensees who are enrolled with the Washington Physicians Health Program. If you're unfamiliar with that, there are certain professions who are able to confidentially go to WPHP and receive guidance, treatment, whatever may be necessary, depending on the condition that they're dealing with. And so as such, I sent this off to Dr. Chris Bundy, the medical director of WPHP. And Chris, I'm going to ask you to go ahead and speak to your comments, if you could, just giving, you don't have to go line by line, but at least speak to, just the general nature of why you made these edits.
Oh, thanks, Micah. Hi, I'm Chris Bundy, Executive Medical Director at WPHP. I had involvement in the initial drafting of this policy. I think most of these are updates to language to reflect changes to statute that have occurred since this policy was initially created. So we're just harmonizing with some of the statutory language, moving away from differentiating things like mental illness or mental health from quote unquote physical conditions, which is actually kind of a stigmatizing distinction that I thought that we've been trying to remove from statute, but also then commensurately wanting to remove from other policy, document, rule, and so on. Okay, we can scroll down. I think that covers those edits for the most part. I think we're just focusing on some of the, oh, maybe we scrolled too far. Do you want me to talk about, trying to think if there's really where the most substantive edits are here. I think just this paragraph in front of you, which starts, while uncommon, illness recurrence or return to substance use. Again, return to use is the preferred term in the addiction medicine lexicon over relapse, for reasons I won't belabor at this point. But I think that we also really wanted to generalize this policy, or at least I did, to cover not only, you know, a lot of the focus here was sort of thinking through the substance use disorder lens. WPHP serves a wide variety of conditions beyond substance use disorders, so really moving more towards the terminology and frame of illness recurrence, and how we manage illness recurrence within the auspices of the program. So we just talk a little bit about that here, and how we respond to illness recurrence within the program, that it doesn't necessarily indicate that somebody's impaired or unsafe to practice. The commission has been historically had confidence in our ability to manage illness recurrence within the confines of the program without necessarily needing to notify them unless there's a patient safety issue. And so we just kind of, this paragraph here just tries to kind of clean that up a little bit. I don't think that there's anything controversial, frankly, in any of these edits, but it's a lot of markup. So it could be perceived as being substantive, but I really don't think that it is. I mean, I'm happy to answer any questions that you all have about any of the edits, if there are questions or concerns.
Sure. Chris, I'll just take a moment to speak to the relationship between the Medical Commission and WPHP, just to clarify. So, number one, WPHP is the statutory therapeutic alternative to discipline under the law. So our licensees have the ability to go to WPHP on their own, or a family member can refer them, or an employer can refer them. You know, when we're talking about physicians and physician assistants, mostly physicians, there's a significant public investment in getting their training going and funding their education, their residency from the federal side, but also on the state side. The state funding apparatus is more targeted towards family medicine, but they are public dollars. So as a result, the approach that has sometimes been advocated in the past as an all or nothing approach of, if you have some sort of a health condition that we need to pull the license, it's number one, it's not supported in the research and the evidence when it comes to treating physical, mental, substance conditions, but it's also been deemed as kind of a waste of a resource. It's better to try and rehabilitate and treat than it is to simply suspend and revoke. So that's why we rely on the Medical Commission, on the expertise that exists at WPHP, both clinical and supportive. We simply don't have that structure in the Medical Commission confines. So while it may be apparent as you read through this guideline that it looks like people can have relapses, that's absolutely true. We do trust WPHP to monitor, and they have a robust monitoring system. We also trust that the contractual and statutory requirements of WPHP needing to refer folks who are not capable of not relapsing, or not being able to stick with their program, or not being able to abide by a non-practice agreement. Those folks get referred over to the Medical Commission with some regularity, and we proceed down the traditional disciplinary path. But the statute in Washington is clear, both on the WPHP side, but also on when the Medical Commission takes disciplinary action. Our job is to rehabilitate first as we can, until it becomes clear that someone is unable to be rehabilitated. So I just wanted to add that context between the Medical Commission. So Chris, any other comments that you wanted to highlight on your edits?
No, nothing with regard to my edits. I just wanted to, maybe reinforce what was said. I mean, this part about illness recurrence within the program, I mean, people should know that, we evaluate that very carefully. In a lot of cases, probably in most cases, that results in an immediate recommendation to cease practice while we evaluate the severity of the illness recurrence. And so, I mean, sometimes illness recurrence, we have worsening depression, we have worsening anxiety. Those don't necessarily warrant a removal from practice, but a detected return to substance use probably would result in a cease practice recommendation until we have time to further evaluate what's actually happening. So I just want people to be misled that we're allowing people to continue to use substances within the program and be outside of their health support agreement without consequence. We're always first and foremost about protecting the public.
Sure. Thanks, Chris. So at this point, let's open it up to the public to see if they'd like to comment on this particular guideline revision proposal.
There's no hands raised and nothing in the chat.
All right. In that case, let's move on to number 3. And so this one requires a little bit of explanation. It's a guidance document that is pointing to a difference guidance document and telling our licensees that they need to use that. So the Vital Health group in DOH has something called WHALES, which is the Washington Health and Life Events System. And so that's within the Department of Health. And so you need, as a practitioner, to complete death certificates through that process. This is simply reiterating that you have 5 days within the date of the death to enter that information. And so this document is pointing our licensees to the DOH documentation and the requirements there. The main reason for the update and the clarification is we do get funeral home directors as well as others who are file complaints on licensees who they feel have not completed the death certificate process appropriately. There are a lot of impacts when that happens, everything from you can't hold the funeral to body transfers and that sort of thing. And so the big thing for us is making sure that there's clarity to the licensees about what the standard is, where they need to do it. And so this is really just this guidance document is effectively a policy arrow to the DOH guidance. Kyle, did you have anything you wanted to add there?
Nothing beyond what you've said. This is an issue that we see at least once a month in terms of complaints being filed by family members, as Micah mentioned, or sometimes funeral home directors. And it is one of those things that it may seem relatively minor to some of our licensees, but it can represent a huge hurdle. So I don't have anything beyond the suggested comments other than to highlight that this is an actual issue that we see on a pretty regular basis.
And I think I'll just not so much in the defense of licensees who have to do this. We do recognize that there is sometimes some ambiguity or confusion about who should be doing this. The most times it is the primary care practitioner, but if you don't have the primary care practitioner, sometimes this falls on the emergency physician. There's some pushback that we've seen from the emergency physician community, simply saying that just because the patient expired in their department doesn't necessarily mean they know why they expired or if they have a relationship with that patient and understand what the lead up to that was. There's also the issue that sometimes patients don't have a primary care provider, and so there is some ambiguity there. So the guidance from DOH does address that, and so we encourage folks to take a look at that. At this point, I'll open it up for any comments from the public and hear what folks have to say if there's any comment.
There are no hands raised, and I don't see anything in the chat.
Well, in that case, Amelia, I will pass it back over to you.
Okay, let me get set up here. Sorry that's huge. Okay. So now we will start our open forum session. And this is a time where interested parties like you can share your thoughts and suggestions on the WMC's policies and interpretive statements and guidance documents as well. We encourage everyone to participate and express their ideas respectfully. And to ensure that all those who choose to participate have the opportunity to speak, please limit your comments to 2 minutes. If you have an idea for a policy or suggestions to reform an existing policy, please use the raise hand feature within the Teams application and you will be called upon when it's your turn to speak. When sharing, please remember the WMC regulates allopathic physicians or MDs and physician assistants. If you have an idea for a different profession, please feel free to send it to the email address on the screen and we will forward it to the right place. And then please keep in mind that at this time, rulemaking does not live within the policy realm. It's only through business meetings or rule petitions that changes to rules can be suggested. And with that, sorry, it's blocking out part of the screen. Oh. I will go ahead and open the open forum. So if anyone has a question or would like to make a suggestion, go ahead, Susan.
Okay. Can you hear me okay now?
Yes.
Okay, and I'm making sure, I think I have my camera on.
You did, and now it's gone, but it's fine.
Is it there now? Okay. Is this I want to make sure I'm in the right area. I want to speak about the opioid prescribing policy guidelines.
So you probably want to talk about the interpretive statement. Yes, this is the appropriate place.
Okay, I'm in the right spot. Great. I just didn't want to waste your time first. Thank you for listening to the community at large. I am a chronic pain patient and have been for over 11 years. I have lupus and ankylosing spondylitis. And I want to share something I just went through within the last 24 hours. Because the physicians are not clear on the prescribing guidelines and what the suggestions are, I encountered an issue where I had some definite problems getting to a shoulder replacement surgery that is needed because my shoulder is totally gone. And because of misunderstandings about the guidelines and what they're in place for, we had a lot of going back and forth. Finally, this morning, after I checked this morning, 15 hours of me on the phone with surgeons and pain providers to get this straightened out. We need to make sure that our physicians are informed and really understand what the guidelines share. The other thing I'd like to share is I think that since we have so many issues with opiates, and I think some people don't metabolize as previously thought they had metabolized, we need to put in place that when we start pain management, there needs to be the test that judges how you metabolize opiates so that this can be used in the guides of treating that specific patient. This is not a one size fits all thing by any means. And I know pain control is going to be something that's in my future forever. I look forward to the next year as you guys make guidelines and listen to those who are actively involved in the process and those ones that have to receive the pain control. And I look forward to seeing the amazing things that you do to support us in the next year.
Thank you, Susan. And yes, the interpretive statements will be on a future meeting, and we are also opening all of the opioid prescribing rules probably in March or April of next year. Those will be open, and we'll start having workshops on those rules. And we'll be taking all your suggestions and comments during that rulemaking process.
Thank you, and I appreciate your guys' time on this matter.
Thank you, Susan. Does anyone else wish to speak or have a question? Go ahead, Gina. You have to unmute yourself. Maybe you can put it in the chat because we can't hear you if you're trying to speak. Okay, well, hopefully Gina can figure out her technical issues. Does anyone else have any comments? There are no other hands raised. So if anyone does have any comment, oh, go ahead, Kat. You should be able to unmute yourself. There you go.
There we go. Is that, I'm sorry. I appreciate you all so much. I'm the Director of Communication, Law, and Public Policy for the American Pain and Disability Foundation. We worked closely with one of your stakeholders, Maria Higginbotham, and you all, and was at a previous meeting regarding changing some of the opioid guidance. I just want to emphasize the urgency of this. I'm in Illinois, so although I'm not a Washington stakeholder, I help people all over. And like Washington, we have the same issue of having states that border us that are not friendly for pain patients or their medical professionals. We just passed a bill in the Illinois Senate unanimously to eliminate morphine milligram equivalent guidance. That's a really important step because we can be a sanctuary for other states. But Washington physicians have the same issue that Illinois physicians is, which is fear. I don't think that fear will be eliminated without emphasizing how important the guidance that you all have and widely disseminating that so that practitioners know, right, that they're not going to get into trouble and how urgent this is. The reason that we pushed it through as fast as we did, and I don't know what it means to say we'll meet in January. Like, I'm just concerned about the enforcement, how soon that could happen. Does that make sense? It's a question, I guess. I just want to make sure that it's clear for pain patients and their providers as soon as possible that you all have changed that guidance. And that's really it. Thank you very much.
Thank you. Micah, did you have a comment?
I'll let you address the timeline because I think what we're talking about is rules and interpretive statement revision, correct? So I'll let you address that, and then I've got a question for Kat.
So for rulemaking, it will be a while. I mean, the recent changes we made will be effective probably in February or March of next year. And then that new rulemaking effort that we will start in about March of next year will take as long as it takes. And then as for the interpretive statements, they'll be probably on the next policy agenda, which is after January. I believe it's in April, maybe March. And so as far as the timeline goes, then, that is like we have the policy interested parties meeting where we discuss it, and then the policy committee meeting where they discuss any changes that they would like to make or suggestions that we've received about changes. And then it goes to the full commission at a business meeting to be voted on. So that timeline is like that. So I'm pretty sure that we are going to add it to the next. So the next policy interested parties meeting after this one is January 30th, and then there'll be a policy committee meeting on February 27th. So those interpretive statements will be looked at in those two meetings.
And as far as the other portion of the timeline, just to be clear, uh, the medical commission doesn't strictly control the timeline on rules. That's set out in statute in I believe in the Administrative Procedures Act. And so there's a series of 30, 60, 90-day requirements for public comment and that sort of thing. So that's why rulemaking does take longer. However, the advantage of rulemaking over, say, passing a bill and overruling, all the rules, is that you actually get medical expertise that gets to substantively weigh in and create those rules in a much less politically charged landscape. My question for Kat is, so you said that Illinois eliminated all MME guidance, but in our experience, that's not been the issue. The issue is the CDC guidance being adopted by institutions as the law. And so our requirements are much less stringent than what the CDC guidance is. But it doesn't change the fact that hospitals, where the majority of our licensees are employed in this state, are the ones who are adopting the 90 MME standard per CDC guidelines. So how are you addressing that, or are you in the Illinois law?
That's a great question, and it isn't strictly a political situation. We actually started at the administrative level. Unfortunately, we don't have an analog to you all in Illinois, so the process is a lot different. And I know that you all are certainly familiar with what the layers of bureaucracy can look like and why it can be hard to push something through in a timely manner. I'm trying to weigh those things because I know there is an urgency here. We do have people who are forced tapered. We have people losing access to their medication. We have providers getting in trouble who shouldn't be, or flagged, et cetera, just based on dosage. So we actually tapped into our state medical society and our pharmacist association to get some support first. And then we worked on it in a bipartisan fashion because we don't think this is a political issue. It's pain. It doesn't discriminate based on your perspective. And we feel that pain patients and pain providers should be protected within the realm of, and what you all had talked about in the summer, we thought was great. It was great progress. The only concern I had was with respect to when can a patient and or that person's provider feel comfortable that, okay, I know this is different and I can do something. Does that make sense?
I think so. I'm not sure that it gets to well, I'll just personally say the frustration that I've had where we try and craft something that, I mean, I think you're aware that WAPIP helped us craft the legacy section, the legacy patient section of our rules, where it talks about taking on, essentially creating a safe harbor for 90 days and maintaining the existing treatment regimen of a new patient. That was one of the big issues that we were having. And then clarifying that we don't actually have an MME restriction. We've got a consultation threshold, and there's about 5 different ways you can be exempt from having to consult a pain practitioner under our rules if you go over that. So it still comes back to the clinics and the hospitals who are looking at the CDC guidelines and saying that's the standard we're applying, and we're going to drop everybody to 90 or below.
Okay, and we didn't implement the CDC guidelines, so that might be a piece of it. Like we don't have it legislatively, but we did in our bill mention that it should be up to clinical discretion and the most updated evidence-based guidelines. So we were trying to allude to the fact that even the CDC has indicated that, hey, our guidelines have been codified as hard thresholds, and that's not how they should be applied.
Right. And like I said, we have not codified those. It's more been a decision at the individual institution and clinic level as to what they're going to apply. And I see, I'm guessing that's Maria Higginbotham, MH.
Mm-hmm. Yes. Go ahead, Maria.
Good morning, everybody. Now, Pat is who helped me with my petition, so I just want to say thank you, Pat. Um, so I don't know if I sent Amelia some documents, and I'm pretty sure that it was put in the meeting packet, but there was a recent announcement by the American Medical Association where they are requesting medical boards, commissions, and whatnot to not use the CDC, as the way I interpreted it, not use any of the CDC um, guidelines, but to go to a recently released federal state medical board guideline. Um, so I don't know if that is any help at all. My issue, and I'm fine, I'm very sick today, so please forgive me because I'm having a really hard time speaking. Is that I'm getting messages and phone calls from people every day and trying to talk them out of committing suicide. And it's so horrific that you hear these people and they're just crying and they can't talk, and I don't know what to do for them or where to send them, and they're too scared to come to the medical board because they think that if their doctors find out about it, that the little bit of medication that they get will get taken away. It would just keep fighting this big circle, and it's just um, it's awful.
Thank you, Maria, and thank you for taking those calls and working with folks. I will say that the medical commission's rules are quite clear that under treatment of pain is considered a potential violation of the standard of care. We do get complaints about that, and you can complain anonymously. So recognizing that there is some potential risk there if the patient provides a lot of detail, because if we're going to investigate, we are probably going to have to pull patient records, and so that there is some lack of anonymity, lack of being confidential. Uh, so yeah, I recognize that that's certainly a concern. Again, I come and we're familiar with the FSMB 2024 policy. In fact, I'm pretty sure we commented on it and provided some pretty substantive suggestions to update it. So for sure we can take a look at that. And to Kat's point, I am aware that there is technically an analog to us in Illinois. Unfortunately, they've had over the past decade some pretty significant funding issues that you can trace directly back to opposition of the medical association allowing fee increases. So their executive director / licensing director / investigative director, he's been a one-man show for a long time. So it's unfortunate, but that's the situation they're in right now.
Well, again, I just want to tell you guys that I am very grateful for everything that you're doing, and we know that it's not easy and that it does take time. It's just that it's the patients on the outside that don't have the time. Unfortunately, I mean, I have people that are going into clinics, and the clinics are telling them that the Department of Health came to their office and told them they could not prescribe over 90 MME. I mean, outright lies to their patients. Majority of them don't realize that that's not the truth, but you know, some are like, that's got to be wrong. It's crazy.
Mm-hmm. And we certainly heard that with the initial release of the CDC guidelines, I think in 2019 or something like that. We even got pictures sent to us saying the Department of Health says that 90 MME is it. We don't have those requirements. There are not inspectors that go out to unlicensed clinics and whatnot and say that. We actually, I can remember one scenario where we were accused of doing a raid on a opioid prescribing pain management doc in a rural area. And we were blamed, and we were like, well, we don't have people with guns. We don't do raids. And as it turns out, it was the DEA that came in. So there's a lot of confusion about who's doing what. The DEA, just for clarification, they are pure law enforcement. They're not looking at standard of care stuff. They've repeatedly stated that that's what they leave it to us to do. So certainly, I would be highly suspect if someone says the Department of Health came out and said anything. They generally stay in their lane with respect to this, but there are 4 or 5 boards and commissions that regulate professions who prescribe opioids, who have all collaborated and tried to come to agreement on what standards we're applying. And generally, they're pretty close. I would say the nursing board is a bit of the outlier, and that mostly revolves around how much or how soon, how often you have to check the PMP as a prescriber.
And none of the boards and commissions have restrictions on the limit. They don't restrict the limit, and they don't have tapering requirements. Even though I think Osteos does, the name of that section is tapering requirements, but there's no requirements in that subsection or in that section that says that you must taper. So,
and I don't want to put Hillary on the spot. I noticed that she's here. Myself and Jeb Shepard from the Medical Association have had years of commiseration on this issue with respect to how do you get, say, the Medicaid agency or hospitals or clinics to recognize that the true standard is what the medical commission and the other boards and commissions put forward, and not the CDC. And like I said, if someone has suggestions, totally open to trying to work those out to see if they're feasible. But unfortunately, we don't control what the hospitals or those unlicensed clinics can put forward as their standards, so long as they're adhering to something.
I think we had a major glitch a couple months ago when the AMDG issued the calculator change. It seems like a lot of the clinics went crazy, and that's when they started tapering. And I'm not sure exactly why they made the decision that they need to taper all their patients just because of one issue with the calculator. But it is very widespread, and I like the one clinic that I am a patient of, but I'm not getting my systemic meds from them. They just maintain my pain pump, but they have 15 offices, and they're tapering every single patient, regardless of what their medical condition is. And it's just gut wrenching. I go in and the practitioner that I see literally closed the door one day when I was there and just talked to me without the nurse being in the room. And he literally broke down crying because he's, I have a boss and I have to listen to him, but this is not what I got in the practice to do. I got in the practice to help pain patients. And here I am, I'm hurting them and I don't know what to do. I don't want to lose my job, but I can't do this to people. So he's thinking of just leaving the practice, period. And that's, it doesn't solve anything.
Sure. Looks like Kat and then PN.
Hillary.
Oh, is that Hillary?
That's Hillary. Yeah.
Oh, okay.
Go ahead, Kat.
I can go second. Oh, are you sure? Okay, I was just wondering what we can do to facilitate providers having this information. And I know there's some things you all can't control. Like if they say that you all told them to do this, I know that's not within your control and it's not your fault. We know that you all have done everything possible to help patients and healthcare professionals, but I'm just brainstorming about like what can we do in terms of like maybe media or something to distribute so that I understand the interpretive statement sounds like it's April, March. So that's great, but that's like 4 months away for many people who are in need right now. I'm just wondering, are there alternate things we can think of that maybe would generate some, media or attention that we could then distribute to practitioners to try to shut that narrative down?
I'm not sure about media. I mean, I think if we're talking about a potential media collaboration, let's meet outside of this with our public information officer who has media expertise. But I can say that our newsletter called Update, which goes directly to our licensees, is going to feature an article about this, dealing with the misinformation and trying to emphasize not only what the rules say, but what the interpretive statement says as well. And Amelia, correct me if I'm wrong. Is that going out later this month, or is that January?
So it'll come out, I think it'll be published January 1st. It'll be sent out. And that goes out to all of our licensees. So it goes out to all
Mhm.
the MDs and PAs in the state of Washington. Whether they read it or not is another matter, but it does go out to them. Hillary, did you want to go ahead?
Oh, hi. Yes, Hillary Norris with the WSMA. Just really briefly, Micah, thank you for noting the conversations you've been having with Jeb on this topic, and I will make sure that I relay my notes in this discussion to him after this meeting, and just appreciate the continued work on this. So thank you.
Thank you.
And then Gina, hopefully you've gotten your mute
There she is.
issue.
Can you hear me now?
Yes, we can hear you.
Oh, I had such trouble on the site. I had to get it on my phone. The page kept going. I don't know if anyone else had trouble, but anyway, I hope I'm not going to repeat some things a few already said that I missed out on, but I'm 69 years old. I have so many problems in my cervical and lumbar spine. 4 bulging discs, stenosis. I have hardware from my head down into the upper back, and I have 4 loose screws. No one will touch me because they said, well, one of the screws is very close to the vertebral artery. And they said that hardware looks, too fragile. 6 surgeons refused to operate on me. But anyway, what I'm so worried about is there any way the state medical commissions can get together, because it doesn't seem like the states alone is somehow getting together and meeting with the federal government, because there's too many medical professionals sitting in jail for just treating pain patients. And I'm not getting, I mean, I'm one of the lucky ones, but yet I still don't. There are 3 to 4 days a month where I know I need something stronger. I cannot be fixed. And every one of us are going to deal with that, whether it's ourselves, our loved ones. Try going through major surgery, which is being treated with gabapentin and IV Tylenol. It's ridiculous. We're all different. There is no such thing. And I also wondered if you had, by any chance, if anyone looked into Colorado and California's, changes that they made, because the federal government acted really in very bad. It's not right, and it needs to stop. And do you have any suggestions that we as pain patients can do that we're not already doing?
I'll address what a couple of things. So the first thing is I'm not totally conversant on what Colorado and California did. I do know that from a criminal prosecution standpoint, California was a test case on an opioid prescriber. I'm not sure I would call that opioid prescriber entirely good faith. The sheer amount that they were doing suggests that there was more than just treating pain. And as I understand it, that conviction went forward, and they had their case proven. With respect to dealing with the federal side, there's a couple of complications. The first one is we're a creature of state statute, and so for us to engage on the federal level requires approval of the governor's office directly. The other complicating factor, as you probably are aware, we've got a new governor coming in, and so we're not sure how they're going to approach this issue. I think the other third complicating factor is that we've got a entirely new administration coming in on the federal level, and we're just not sure how they're going to approach us. We don't know if they are going to take action unilaterally or if they're going to take action based off of perceived state ideology. I can tell you that if that's how they're going to approach it, we're all going to lose. It's just not going to be a good outcome. There are occasions where we can utilize the Federation of State Medical Board resources. They have a DC office and they do engage on these issues. So we can certainly raise it to them. As far as what patients can do, it's reach out to your federal congressional representative and get a meeting, make them understand what you're dealing with. Make sure you're directing them clearly to the CDC, because in my opinion, that's where a lot of this issue comes from. I appreciate what the CDC did with their updates. And as you have seen, the medical commission was responsive. We are in the process, or if we have not done it already, we added sickle cell, and I believe we added some language giving more flexibility around biological testing, specifically stating just because you get an aberrant test, whether it be positive or negative, it's not a reason to dismiss someone. And so just really encouraging practitioners to work with their patients to keep them on the regimen, keep them in the practice.
Thank you very much. I appreciate that. And I know there are some not so good medical professionals out there, but not as many, over 3,000 in prison. That's ridiculous. And most of that, a good bit of them were only for prescribing over that 90 MMEs, which is a fictitious number anyway. So thank you.
If you've got a resource or a list about what practitioners are in prison and where, I'd be curious to see that. If you have
Sure.
that handy.
I will send that. Yes.
Thank you.
So are there any other comments or questions on any of our policies or interpretive statements or guidelines? Go ahead, Maria.
I just a quick question as we wrap up here. In your newsletter that you're going to put out when January or whenever that's going to come, in the discussion about tapering, is there a way to put some language in there that says that tapering is against the state policy, that it's below the standard of care?
I don't think we say that it's below the standard of care. We just say that there's no requirements for tapering. Like, we've never had requirements in rule for tapering. So it just addresses that, and it talks about, like you and I've talked about in the past, Maria, it talks about how when a doctor or a PA is treating a patient, they should be treating the patient holistically, and it should be a decision between the doctor and the patient about how they're going to prescribe. So it does encourage them to do that, and that there are no tapering requirements. And then it calls out the recent information from the CDC that is being misinterpreted. So it does, most of the things that you and I have discussed in email are going to be in that article.
Awesome. All right. Thank you.
Sure. Did you have anything to add, Micah?
No, you covered it great.
Okay. Are there any other questions or comments? Okay, well, if you do have any questions or comments, you can email that medical.policy@wmc.wa.gov. That comes to me and I distribute it as needed. And then if you have any questions about rulemaking, you can email medical.rules@wmc.wa.gov, and I will get back to you on those as well. Right. We will adjourn then. Thank you, everyone.
Thank you.
Thank you.
Thank you all so much. We appreciate you.